No one ever wants to hear they have breast cancer, but today, there's new hope. New detection tools can help find the disease early. And even in those whose cancer has spread, science, strength, and spirit are rewriting the story. They're not just surviving, they're living fulfilling lives. Our expert panel will discuss the breakthroughs, and you'll hear from survivors with powerful stories to tell next on Beyond the Diagnosis, Living Longer with Breast Cancer.
Thank you to the Eunice Joyce Gardner Charitable Foundation for its leadership support of the Health Channel.
Welcome to Beyond the Diagnosis, Living Longer with Breast Cancer. I'm Carla Hill. Thousands of women in the U.S. are diagnosed with breast cancer each year, and I was one of them. But that diagnosis isn't nearly as devastating as it once was. Today, many more women are cured of their cancer, or they're living longer, fulfilling lives, even as they continue treatment. It's all part of the journey, as this survivor discovered.
Bravery, I think it's changed. At the very beginning, bravery was getting through breast cancer. Bravery 10 years later looks like accepting everything that was and even everything that will come as a result of this diagnosis, because this diagnosis is for life. So when I finished treatment, I was tackling all kinds of things. You know, I did multi-sport adventures, I was doing these triathlons, and it was an awesome way for me to celebrate being a survivor. After I crossed all those finish lines and having gotten through all that chemo, I felt like I was putting weight on my shoulders to be so much more. And so when that adrenaline, when it wore off, I just felt the weight of being better, doing more. Physically, I didn't feel as good because I had gained weight, because I wasn't doing the things that I had been doing. I felt like I was being very hypocritical, and it set me back emotionally. What helped open the door to getting out of it is acceptance and acknowledgement that peaks and valleys are going to continue to come. I came out of that valley and I acknowledged that there may be another one. This is my chemo scar. This is my battle scar. When I go through things that are really tough, even still, I look at this scar as a reminder that I am able to overcome. My advice, having gone through this, is when you feel yourself sinking before you drown, you have to ask for help. Kevin was somebody who saw the truest part of me. We had the kind of relationship where I had to let him know on days when things were good and things were not so good. And I think having that level of support was very important. We just recently got married, bought a house, but I think the biggest thing that has gone on from beginning to the end is just an evolution of not accepting cancer as the definition of who I am, but understanding that everything I've gone through is made up into the fabric of who I am now.
Such a powerful message there. Now, let's introduce our panel. Joining me in the studio is Dr. LaToya Lewis. She's an associate professor of clinical at the University of Miami School of Nursing and Health Studies. And Dr. Anouchka Coste is a breast surgical oncologist at Holy Cross Health and associate adjunct professor for the University of Miami General Surgical Residency Program. Joining us virtually is Dr. Susan Kesmodel, the Director of Breast Surgical Oncology at the Sylvester Comprehensive Cancer Center at the University of Miami. Welcome, all of you. Dr. Coste, Carletta talks about wanting to do all sorts of activities after finishing her treatment, but she's also has the emotional ups and downs. And that seems to be something many breast cancer survivors experience. I know I did. Can you speak more about that?
Absolutely. I think most patients have a hard time transitioning from being in active treatment where they're in a fight or flight mode to save their lives, and then once the treatments are over, they realize they're in the surveillance stages, and that's a hard adjustment for people. Many patients go through adjustment disorder, even depression, anxiety, and oftentimes we'll warn patients and say, hey, it'll take a period of adjustment for you to get back to your life and realize that it's going to be okay, and you don't have to necessarily worry so much, but we're going to continue to monitor that while you're finished treatment.
And Dr. Kesmodel, surviving breast cancer, even just being diagnosed with it, begins with an emotional and physical journey. What would you say are the most common feelings or roadblocks that patients and their loved ones should prepare themselves for?
So as you mentioned, it is a very emotional journey for patients when they have a diagnosis of breast cancer. They're clearly concerned about the immediate side effects of treatment, including chemotherapy, and also the physical changes that occur with the breast cancer diagnosis and treatment. And of course, there's also the fear of dying. We do lose approximately 40,000 patients to breast cancer every year. The good news is that with screening, most women are diagnosed at an earlier stage. And when women are diagnosed at an earlier stage, we're able to de-escalate therapy and still improve outcomes, so the side effects are fewer.
Dr. Lewis, Carletta also talked about getting help. For anyone watching today, are there warning signs that a loved one, a friend, might need some help?
Yes, so essentially there are some physical signs that you can assess with the individual or your loved one. You know them best. In addition to that, the psychological elements of withdrawal. This individual does not find joy in certain activities anymore. You see some shifts in their personality. They're becoming depressed, they're becoming anxious, they are having some negative self-talk, which is a concern as well. So we're trying to look and create a bridge. For example, if this person is very religious or spiritual, you're seeing them withdraw from that or speak negative regarding some of their practices. All of these things are minor signs that are little alarms, that I like to say, to talk to that person about, to say, you know, it's a safe space, let me know how you're feeling. If we need to go to a rage room, let's go to a rage room, just so you can let it out, because this individual is experiencing so much, and sometimes they're trying to keep it together for their family, for their loved ones, so they're putting on a mask. Give them a safe space so they can take that mask off and really feel.
Dr. Lewis, if you will, talk about support groups and what might be the benefit of support groups.
So support groups really give you an outlet to take off that mask and be in a place where there are others who have experienced what you've experienced. And the benefit of support groups, I like to say post-COVID and even pre-COVID, is we have support groups that are available virtual. We have support groups that are available in person. We have support groups for your children who are dealing with a parent who experienced cancer. We have also loved ones, being a caregiver with someone who is experiencing cancer. So there's a piece of the pie for everyone to get the help they need to show up as their best self. And that's essentially what the support groups do. It brings you to your best self.
Well, you know, the simple truth is, despite advances in prevention science, the number of women being diagnosed with breast cancer is continuing to increase. Each year, about 270,000 women are diagnosed with breast cancer. More than 40,000 will die from the disease. Women 50 or older are the most likely to develop it, but younger women are at risk too, and that's the leading cause of cancer death for Hispanic and non-Hispanic Black women. Dr. Kesmodel, women who have gone through menopause are the ones who could be at highest risk. Why is that? And how often do you recommend they get mammograms and other screenings? And is there an age when a woman no longer needs to get screened?
So age is one of the risk factors for developing breast cancer, and it's more common in postmenopausal women. And this is likely due to just the cumulative lifetime hormone exposure and potentially cellular changes that occur as we age. We typically recommend that average risk women start screening at the age of 40 with mammography. And then we recommend that women get an annual screening mammogram. Some high-risk women, however, should start screening earlier, and sometimes we use supplemental modalities to screen high-risk women. It used to be recommended that we stop screening at the age of 75, but I usually like to individualize this for each patient based on their overall health and also their family history. So I wouldn't say that there's an exact age at which I would stop screening patients.
Dr. Coste, younger women are being diagnosed more, and sometimes their risk is even higher. Is there an explanation for that?
Well, oftentimes women that are younger that are diagnosed or are at higher risk for developing breast cancer have a strong family history and are not previously diagnosed with a genetic mutation, have a history of chest wall radiation, or have a BRCA1 or BRCA2 or some other genetic mutation that increases their risk. Typically, we recommend those women to start screening earlier at the age of 30 or 10 years before the first degree relative, and oftentimes we'll add MRI as a supplemental screening tool in addition to the mammogram to kind of get ahead of finding any cancers that they may develop in the future. So that's kind of the baseline of what we do for those women that are higher risk.
Dr. Lewis, Hispanic and Black women seem to be at the highest risk for breast cancer. Why is it that they are at a higher risk, and what obstacles might they have found on their journey?
So there are certain reasons why they're high risk. There's some evidence that shows variation in socioeconomic status. There shows variation in awareness and knowledge regarding breast cancer risk, demystifying some of these elements in those communities about who's at risk for breast cancer versus who's not. There are other elements regarding historical information. There are many cultural influences in those groups where we don't discuss certain cancers or terminal illnesses or chronic diseases. Individuals, if they go to the doctor, they're not disclosing any personal issues. So as being from Trinidad, as you are, and fellow Caribbean individuals, there are times it is a stigma if you have cancer and you're going to die immediately. So I might as well not even look for any help. So we're trying to really address in this community the individuals who are not seeking help, as well as they're not following up, because they can go for a mammogram and not follow up when they say you need repeated tests. So what is the barriers related to that? It could be perception in regards to I don't want to hear bad news. And that is a factor that we're trying to bridge the gap with. In addition, we're looking, I was part of a All of Us campaign with National Institute of Health. We're trying to incorporate more underrepresented individuals in research so we can really assess and target some of these populations and really go into the community compared to waiting for them to come to us. So those are the elements.
That's wonderful work, wonderful work. While the number of women diagnosed with breast cancer is dropping overall, the number of women developing aggressive types of breast cancer are rising. The Sylvester Comprehensive Cancer Center recently released the findings of studies about Superfund sites and the link to breast cancer. Part of what they found was women living near these sites are more likely to develop aggressive breast cancers. Dr. Kesmodel, can you tell us more about what they found, maybe a brief definition of these Superfund areas, especially also about the rise of aggressive breast cancers?
Yes, so as I mentioned, we know that there are risk factors for breast cancer. Some of them are modifiable and some of them are non-modifiable, such as age and genetics. And lifestyle choices, but the research regarding association of breast cancer risk with environmental factors is more limited. So Dr. Kovets and her team were interested in looking at whether living in proximity to something called a Superfund site was associated with presentation of breast cancer and also the type of breast cancer that developed. Superfund sites are areas that have been designated in the United States as areas of hazardous waste that pose a risk to human health or the environment. And there are currently 52 sites which are listed in Florida. So Dr. Kovitz and her team looked at women who were diagnosed with breast cancer, first between 2015 and 2019, and they looked at proximity of neighborhood to a Superfund site, and they found that those women that lived closer to one or more of these Superfund sites were more likely to be diagnosed with advanced breast cancer at diagnosis. And then in a second study, they also looked at the type of breast cancer, and they found that women living within 4 miles of a Superfund site were more likely to be diagnosed with triple-negative breast cancer, which is an aggressive type of breast cancer.
And Dr. Kesmodel, are we finding Superfund sites around the nation?
Yeah, so there are over 1,000 sites across the nation, and there are sites that are earmarked for investigation and potentially cleanup by the Environmental Protection Agency. And I think it's important, obviously, for the community to know about these sites and the potential impact of living in proximity to a site that it might have on your breast cancer risk and also your breast cancer presentation.
Dr. Lewis, a lot of these families that live near the Superfund sites are underserved communities. Are there any government or community programs that can be recommended to our audience that can help them if they need to seek help with a cancer journey?
Yes, so there are different programs. There are some programs that are funded by grants, as well as some programs in alignment with hospitals. So there is one program in particular throughout South Florida. They actually have a van, so similar to the blood donation van, and they go around and do mammogram screenings. In addition to that, there are nurse practitioners, students, physicians, a collaborative team that can come out and do additional screenings as well as clinic visits, and they're bringing that element to the population. In addition to that, there are different health fairs that are trying to help do just paper screenings at least and encourage people to continue. In addition to that, throughout the South Florida area as well as nationally, because of these Superfund sites, we're looking to see if we can start detection early and then also try to mitigate the challenges or barriers with actually showing up for an appointment and showing up for follow-up appointments. So that's why telemedicine is coming into play as a helpful option to bridge that gap, because some of the underserved or underrepresented individuals are multitasking with life and other things like everyone else is. So telemedicine is really trying to create a bridge. If you need a follow-up, or even if you just want to find out if your mammogram was fine for this year, let's get an opportunity to actually bridge that diagnosis process.
Dr. Lewis, I want to stay there. Are there environmental issues that women should be aware of that may contribute to health issues?
Yes. So as Dr. Kesmodel mentioned, we have environmental issues where individuals are close to dumping areas. Individuals are close to warehouses that are manufacturing things. So we have exposure in the air, as well as there are groups in regards to housing. How is housing having an impact regarding mold or asbestos or any other elements having an impact? We're also looking throughout this process at food. There are certain foods and how we cook food that is having an impact with the individual's overall health. So we're looking at a full picture and a holistic view. In addition to that, focusing on individuals asking their medical history, because the more information you have about your family history as well as your personal history, in addition to your environment, we can actually determine risks, as Dr. Kesmodel said.
Dr. Kesmodel, back to you. One of the studies looked at triple-negative breast cancer. What were their findings?
Yeah, so in that study, they, again, they were looking at whether living in close proximity to a Superfund site was associated with triple-negative breast cancer, and they found that there was an approximately 30% increased risk of developing a triple negative breast cancer if you live close to a Superfund site. And triple negative breast cancer is a unique type of breast cancer because most breast cancers express hormone receptors, estrogen receptor and progesterone receptor, and we're able to target those particular receptors for treatment. But triple negative breast cancers don't have those receptors, and therefore the mainstays of treatment for triple negative breast cancers are chemotherapy and immunotherapy. So these breast cancers are much more challenging to treat.
Dr. Coste, do you have any input on why triple negative is so hard to treat? We learn what triple negative is, but why is it so hard?
I think Dr. Kesmodel just said it. I mean, it's really because there are no targeted receptors that we can use the way we do with estrogen receptor positive or diseases or HER2 positive diseases, as some people may have heard. But truly, it makes it more difficult to target and get rid of these cancers, as stated before. So.
I want to add and be transparent that I am a 2-time breast cancer survivor, and both of my breast cancers were triple negative. And I'm here. So if anybody is watching, I'm here. I was diagnosed at stage 2. I did have to do chemotherapy for my first cancer. So Dr. Coste, with that in mind, triple negative cancers are being treated, and what is the rate? Why is it increasing? And how does the stage of the diagnosis play? What does the stage of the diagnosis play in terms of survival of those with triple negative?
Well, triple negative cancers, like Dr. Kesmodel said, are typically treated with chemotherapy, and the later stage that someone presents with triple negative cancer means they have to undergo chemotherapy before surgery or radiation, and oftentimes these cancers are typically more aggressive and can spread to the rest of the body, which makes, again, treatment a little bit more challenging in that regard. But with the advent of immunologic agents such as Keytruda, that has kind of changed the game for a lot of these patients, and we've seen a lot of improvement in survival rates for them, as well as not only that, but surgical outcomes as well. So that's probably the biggest challenge, is making sure we diagnose them early. There's also an association with triple negatives for Black women, as well as for younger women and women with BRCA or BRCA1 or 2 genetic mutations. So those cancers tend to be a little bit more aggressive in that regard.
Dr. Kesmodel, what about the immunotherapy? Can you expand on immunotherapy as treatment for triple negative or any cancer?
So one of the things about triple negative breast cancer is that it seems to have a specific immunologic environment which allows immunotherapy to work well. We are testing immunotherapy in other types of breast cancer, in the estrogen receptor positive, HER2 negative breast cancers. And there have been some studies more recently which have shown that in particular instances when there seems to be a favorable immune environment around the tumor, that immunotherapy in those instances also works well. We're currently using immunotherapy for other cancers, including melanoma, where we've had great success, and also lung cancer. So we're really applying immunotherapy where we're getting our own immune system to try and attack the cancer more frequently. Triple negative breast cancer just seems to be one in which immunotherapy works really well. But I think we will find other types of breast cancer that respond well to immunotherapy.
Thank you, Dr. Kesmodel. There are many more reasons women can develop breast cancer, and one of them is having a mutation in their BRCA or BRCA genes. Let's take a look at this video.
Let's talk about BRCA1 and BRCA2, 2 genes that can affect your cancer risk. Everyone has BRCA1 and BRCA2 genes, one from each parent. Their job is to protect against certain cancers. Sometimes mutations or changes occur in these genes that are passed down through families. When that happens, these genes may not work properly, which raises your risk of breast, ovarian, and other cancers. But if you learn you have a BRCA1 or BRCA2 mutation, there are things you can do to manage and lower your risk. Having certain cancers in your family, like ovarian or breast cancer in women, male breast cancer or aggressive prostate cancers in men, or pancreatic cancer in women or men, may mean there's a higher chance of a BRCA1 or BRCA2 gene mutation in the family. Knowing the cancers that family members have had can help a healthcare provider better understand your risk and guide your next steps. Learn more at cdc.gov/cancer/BRCA.
Besides the BRCA mutation, there are other risk factors too. The risk of developing breast cancer increase with age. Starting your menstrual periods early is a risk factor, as is late menopause. Another risk factor is having dense breasts. And of course, your family history can play a role. So let's tackle the risks individually. Dr. Kesmodel, how common is BRCA gene mutation and who's at risk for having the mutation?
So we know that approximately 5 to 10% of breast cancer, of women who develop breast cancer, have a gene mutation, and the majority of those are BRCA1 and 2. There are other genes that we have also identified now as being high risk. For example, P53 is one, and STK11, and then there are some that have lower risk. But BRCA1 and BRCA2 are the most common. Typically, when we look at families where there is a hereditary breast and ovarian cancer syndrome, which is what the BRCA genes are associated with, you will see multiple generations where women and sometimes men have been diagnosed with breast or ovarian cancer. But it is the minority of women with breast cancer who carry one of these gene mutations. But when we see a suspicious family history, we do consider genetic testing, and in fact, genetic testing is recommended for all women with breast cancer age 65 and under, and that's typically something we do in the clinic. But that's why I think it's very important for women to know their family history, and men as well, because sometimes you can see this pattern of cancers occurring in the family, and you can get genetic testing before you develop the cancer, and then we can have interventions for risk reduction rather than cancer treatment.
And Dr. Lewis, how does one test for BRCA mutations?
So an avenue of testing for BRCA mutation is going to your healthcare provider, and your healthcare provider will do some screening, ask you additional questions about your history, family history, and then that genetic testing based on if you have insurance or without insurance, they'll guide you through the next steps of what it looks like to get the test done. This is a serum lab test, so we are checking in regards to your blood and looking at those aspects. As a reminder, it is from your father as well as your mother, and then we're looking for that mutation. Once that is present, the healthcare provider will then follow up with you and go through additional deep dive in what is found, and then determine other screening criteria for different types of cancer.
Dr. Coste, why is early menstruation a factor?
Well, as we spoke before, the risk of breast cancer is also linked to a lifetime risk of estrogen. So the earlier you have your menstruation or you begin menstruation, the increased lifetime exposure to estrogen. Same goes with having late menopause, as we know. So that overall exposure, lifetime exposure to estrogen, which acts in the breast tissue to proliferate those cancers, is one of the causes, and that's what contributes to developing the cancer.
Dr. Kesmodel, what is meant by dense breasts, and why is having them a risk factor here?
So a lot of women think dense breasts means when you feel your breast tissue, it feels dense. But actually, dense breast is the way we describe the way breast tissue looks on a mammogram. And there are 4 categories that we use, from fatty to very dense. Dense breast tissue has more glandular tissue, and this is where the breast cancers develop. And so this is likely why it increases the risk. And it also makes it more challenging to identify cancers on mammography, because dense breast tissue is white and cancers show up as white on the mammogram. So it can often be more challenging to identify a cancer with mammography in dense breasts.
If you're watching and your doctor has said to you that you have dense breasts, here are additional screening options besides regular mammograms that can help find cancer if it's present. This next video talks about one of them.
We encourage women who have dense breast tissue to consider supplemental screening.
One of the screenings you may hear about is called MBI, a test developed by Mayo Clinic. It's done in addition to a mammogram.
So an MBI is a molecular breast imaging test.
It uses a radioactive tracer that can identify cancer cells.
And since breast cancer is growing quickly, it's recruiting blood flow, has more energy than the surrounding breast tissue, it will uptake that radio tracer more so than the normal tissue.
And by doing so, it lights up and becomes clearer to see for a radiologist compared to the normal surrounding tissue.
And then the contrast mammogram shows the cancer clearly.
To find out if MBI or other screening options are best for you, talk with your healthcare team.
If you have dense breast tissue, really consider supplemental screening because we know that detects a significant number more breast cancers than mammograms alone.
For the Mayo Clinic News Network, I'm Dee Dee Stephen.
While we're on screenings, Dr. Lewis, can you talk more about 3D mammograms?
So 3D mammograms looks at the breast tissue through 3 different views. And essentially, this is another opportunity where we can actually do a deep dive and look at different aspects and different views of the breast. There are some times when certain patients may either have dense breast or unable to appropriately identify what's going on. So I'm a person who has dense breasts, you know, and I actually had to get a biopsy done, and they had to actually identify because the goal of these diagnostic tests are to make sure we assess early and intervene early. So if you have dense breasts or if we're unable to identify that breast tissue effectively and differentiate between cancerous and non-cancerous identifiers, if we're unable to do that, then the 3D is an additional support.
Dr. Lewis, another question. As you're instructing the future nurses, future physicians, scientists, how is AI playing a role in diagnosing breast cancer?
So AI has been showing a pivotal role of getting information from the patients themselves, as well as used as a component where we can help in certain AI components. They are building a triaging system. So let's early identify any additional risk factors, collecting data, and let's add on to risk factors that are modifiable and non-modifiable. So it's helping contribute to research. Additionally, AI is helping us in regards to some patients can take certain apps home, talk to their family members, do a triaging tree, demystify any family or history diagnosis, so that's an additional element. And then third, we're trying to help that bridge with caregivers. So how can AI help us identify any cultural, religious, spiritual elements to provide holistic care? And if we have to transition towards palliative or end-of-life care, how can we support that individual, that family throughout that process? So it's helping us predict as well as it's helping us engage, because we know after the visit, some patients may have questions and at times they may feel neglectful to call back. So that can help us create a bridge of education and engagement.
Dr. Coste, if we can talk about family history, and how does that affect a woman's potential for breast cancer diagnosis?
Well, it can contribute quite a lot, actually, even without having, as Dr. Kesmodel mentioned before, you know, only 5 to 10% of women have a genetic mutation, but there are some women who are do not test positive for these genetic mutations and have a strong family history, so predisposition to cancer. So that makes them a little bit higher risk, and those women need to be screened early with MRI or molecular imaging, as well as contrast enhanced mammography as well, in order to pick up those cancers early and identify women that can be potentially given prophylactic mastectomies, in a sense that they may develop other risk if they have non-proliferative diseases as well.
Before we leave risk factors, I want to mention that while the numbers of men who develop breast cancer are much lower than women, they can still be at risk. Dr. Kesmodel, what risk factors should men know about?
So several of the risk factors for women are also risk factors in men. So increasing age, family history, prior radiation to the chest wall for other illnesses, and also medical conditions that increase estrogen. And in particular, patients with men with a BRCA2 mutation, one of the high-risk gene mutations, are at a significantly increased risk of developing breast cancer.
One of the most common breast cancers that both men and women get is called lobular cancer. And although common, it can be difficult to find. But once found, it's not necessarily difficult to treat, as our next video explains.
There are many types of breast cancers, and one of the most common is lobular breast cancer.
Lobular breast cancers are almost always estrogen receptor positive, or they grow in response to estrogen. And the reason that lobular cancers are different than ductal cancer cells is when you look at those cancer cells under the microscope, they grow in single file lines compared to how ductal cancers typically grow in lumps or tumors,
which forms in the milk-producing glands of the breast. Because this type of cancer doesn't form lumps, it can be overlooked during self-exams and even mammograms. If you notice a change in your breast, like an area of puckered or unusual skin, a thickened area under the skin, or a nipple discharge, you should see your doctor.
Thankfully, most of these lobular cancers are hormone-driven, and we have great anti-hormone therapies, anti-estrogen therapies. And so even if these cancers are diagnosed at a later stage, maybe they're not all stage 1s, there can be stage 2 and stage 3, those are still very much curable breast cancers. And it may mean that the patients have a longer treatment journey, right? They might have more significant surgery. They might require additional medications that a patient with stage 1 cancer may not have, but still the goal is ultimately cure.
Dr. Coste, the video talked about this particular cancer being treated with non-hormone therapy. Can you go into a little bit more about how this cancer is treated?
So we've learned from our experiences with COVID that oftentimes there were women that we couldn't treat right away with surgery, so we would put them on this what we call endocrine therapy or anti-hormone, anti-estrogen therapy. These therapies would actually stop the cancers from growing, and recent ASCO data has suggested that they compared this what we call neoadjuvant endocrine therapy to neoadjuvant chemotherapy, and there's been great success in finding that these patients have done much better long-term with disease-free survival, extending their lives, starting with the endocrine therapy to treat these lobular cancers, which don't typically respond well to chemotherapy.
Breast cancer is divided into stages. 2 and 3 were briefly mentioned, but in the video, there are a few more. Stage 0 is non-invasive. Stage 1 is invasive cancer in a small area. Stage 2 is a larger tumor, and it may involve the lymph nodes. And stage 3 is where the cancer has spread throughout the breast and lymph nodes. And in stage 4, the cancer has spread to other parts of the body. While the number of women developing breast cancer is rising, the good news is the number of women dying from the disease is shrinking. A major reason for this is that doctors and researchers are finding new treatments and ways to fight breast cancer, including metastatic cancer that's spread to other parts of the body. That's the most dangerous form of cancer. But more and more women are living fulfilling lives despite being in stage 4 and having metastatic disease.
I work as a county court judge.
Judge Audrey Moran doesn't shy away from a challenge, whether in her legal career, solving issues in her community, or even her health.
We were treating the metastatic breast cancer in my abdomen. I began noticing that my balance wasn't very good, and then I started limping.
Scans in early 2024 showed the cancer had spread to the lining of her brain and spine. Treatment would pose another challenge after Judge Moran developed an infection where a port would deliver chemotherapy into the lining of her brain.
I said, we're going to have to figure something else out. And my wonderful oncologist, Pooja Advani, said she thought she had an idea because a new chemo had come out that she thought might be just the right thing for me.
Judge Moran's care team was able to deliver a newly approved therapy through a port in her arm. The results were better than expected.
The last scan I got of my brain, the results were that the brain cancer has resolved. And I got to tell you, I couldn't even believe it when I read it on my report and showed it to my husband and said, tell me if you think this means what I think it means. And then, of course, talked to my neuro-oncologist, and she said, Audrey, we just don't see results like that.
It almost brought me to tears to have seen how she was in 2024 when she was going through this journey and the remarkable clinical progress that she has made.
Follow-up appointments have confirmed that the treatment is still working for the metastasis in her abdomen. Beyond her diagnosis, Judge Moran remains active with her family and career.
You know, my life is back. I am at work, and I'm getting to do that work that I love.
In late September, Dr. Advani and Judge Moran had a chance to meet again.
My heart was just filled with so many emotions, but the biggest of gratitude, you know, to all the people that have worked as a part of her team to get her there.
I'd gotten to the point where I almost didn't want to try anything anymore, and she really helped me realize this wasn't the time to give up. It was time to keep going, and boy, I'm glad I did. I'm really, really glad I did.
For the Mayo Clinic News Network, I'm Alex Ositis.
That's such an inspiring story, and it's a glimpse of what's possible now for women with metastatic breast cancer. Dr. Kesmodel, Judge Audrey told us in the video that she was being treated for both the cancer that spread to her brain and her abdomen while also treating her breast cancer. How effective is treating different types of cancer separately from breast cancer?
So really one of the challenges that we have in treating metastatic breast cancer is treating brain metastases. Many of the therapies that we have don't cross the blood-brain barrier, so they're not effective in treating brain metastases. But we do have some newer medications that are very good at treating brain metastases and also good at treating metastatic disease elsewhere in the body. So when we have patients who have disease elsewhere in their body and also have brain metastases, we have to be very careful in our selection of treatments so that we're able to treat both areas at the same time. And sometimes it is a combination of chemotherapy or newer medications called antibody drug conjugates, sometimes targeted therapies, and sometimes radiation therapy.
Dr. Coste, we mentioned earlier in the show the survival rates for breast cancer are increasing. Mm-hmm. Is it that treatments like these are allowing women to live longer?
Absolutely. I think, most of the patients that I see that have either developed aggressive forms of cancer or metastatic disease can go into essentially remission after they've received treatment with these targeted therapies. As Dr. Kesmodel mentioned, I think these therapies are allowing patients to live a lot longer and live with what they used to believe was terminal disease, which is now just living with breast cancer.
Dr. Lewis, your thoughts on this as you walk your students through these halls and see these stories?
Yeah, I really put my hat on to the judge because I noticed that there are some patients that really lose hope. Mm. They feel that, you know what, enough is enough, let me have good quality of life. And we always want, with the nursing students, we talk about what does quality of life mean to you. And essentially most patients, from all of their stories, I get that they want to go from confusion to clarity. Let us know what the next steps are. Be honest with us. Let us process it, and then we can engage. So I appreciate hearing that story because a lot of these patients are really experiencing inner turmoil with, should I continue or should I just stop? And that's something where we want to look for talking to the patients, but giving them realistic expectations as well. And knowing that the research is improving, the care is improving, we're reducing those numbers, but we need to continue to see those numbers get reduced from year after year.
Dr. Kesmodel, metastatic or stage 4 breast cancer is incurable, but with new treatments and drugs, it seems the thinking is changing from being a death sentence to now living a long time with breast cancer. Do you feel that way?
Yes, I think ultimately we would like to think of it as a chronic illness. I don't think we're quite there yet. But the pace at which we are developing new treatments for metastatic breast cancer in general, and other cancers has increased significantly. So our goal, as mentioned by Dr. Coste and Dr. Lewis, is to individualize the care for each patient, figure out what the goals are, try and provide treatment, but also limit the side effects and provide quality of life. And with some of these estrogen receptor positive tumors, we have many, many lines of therapy that we can give patients. And so we are seeing longer survival and better quality of life.
Dr. Coste, Dr. Kesmodel just mentioned there's many lines of treatment. And with all of the treatments that are available, how do you choose the right one for your patient?
Well, that's all based on the biology of the tumor. We look at the morphology of the tumor. We work with, as a team, typically, most, Dr. Kesmodel, I'm sure Dr. Lewis works with a multidisciplinary team. So we come together with other health professionals such as radiation oncology, medical oncology, to decide what the best treatment plan is, especially when patients develop recurrences or are not responding to treatment. We look at all other alternatives. We come together as a team to best suit the patient and come up with the best plan so we can improve their quality of life, but also their overall life. So,
Dr. Lewis, new treatments start with clinical trials. How might a breast cancer patient find out about a trial?
So there are different ways. Number one, they can still sign up for the National Institute of Health All of Us campaign. It has shifted a little bit regarding the sign-up process. In addition to that, you can talk to your healthcare providers. There are times that you could sign up for clinical trials because you're using one particular medication, and that may give you the opportunity to determine the effects. Talk to your provider as well. Keep a connection with the treatment, and then you can also sign up for additional newsletters through that process. And some advocacy groups do announce that there are different clinical trials available, and I know at times some individuals may be a little hesitant to say, okay, I don't want you, researching or doing anything with me. And what we need to understand is either that will impact your care or it'll impact the care of someone who may be diagnosed with a similar illness. So we have to really educate and let them know the length of the clinical trial as well as how it's going to impact them, because overall the patients want to know, how is it going to affect me? How is it going to affect my family?
Dr. Kesmodel, what does a doctor look for when deciding if a patient is right for a clinical trial?
I think we first start by looking at the stage of disease, how many lines of treatment the patient has received. Some of the clinical trials are treatment trials. Some of them focus on survivorship issues, so they're not treatment trials, but they're looking at lifestyle changes, wellness. We also want to make sure that the patient can comply with all of the treatment. Clinical trials can be challenging for patients. They need more frequent visits. Sometimes the treatment can only be given at one site, although we do try to have clinical trials at all of our satellite sites. And then we have a whole complement of trials from early stage to metastatic disease. And we also have, at Sylvester, we do have a phase 1 program. So again, we look at where the patient is in their disease process and try and figure out what's best for them. And as Dr. Lewis already mentioned, there are many clinical trials that are out there, and it's not going to be right for every patient, but we do try and look for the treatments of tomorrow. That is one of our goals. Our goals are to give the best treatment we have today, but we also want to try and figure out what treatments we can offer patients tomorrow, and the best way for us to do this is through clinical trials. And all the advancements we've made in treating cancer have been made through this process, or many of them.
While it may not be possible to prevent developing breast cancer, ignoring the possibility is not the answer, as we've mentioned. Here's one woman's story about facing a family history of breast cancer.
Living with hereditary risk of breast cancer feels like you're just living a normal life and then quickly going right back into a black cloud of, will this catch up with me? So almost every woman in my family has had breast cancer, and I want to do anything I can to not have history repeat itself. So when I was thinking about starting a family and went to my OBGYN for my yearly checkup, she sort of took a step back with the family history and said, wow. She said, you know, has your mom had genetic testing done? And if not, she needs to, and this needs to be something that you're thinking a lot about. So my mom found out that she was negative for BRCA1 and 2, and I'm also BRCA negative as well. It was certainly something to be relieved about, but it's undeniable that there's some hereditary cancer in the family that is yet to be discovered. And it just sort of leaves you feeling like you want to do something to not have this happen to you, but you don't know what this might mean. But, you know, in my family, generation after generation, the mentality was to not think about it because it's scary. But now my mentality is I am so fortunate to have access to testing and to amazing physicians. And I want to stay ahead of this. I want to be super vigilant, and I don't want to have cancer.
So, Dr. Coste, and to everyone watching, being proactive and staying on top of your screenings and tests does make a difference. But what advice would you give to someone like Lauren with regard to family history and her breast cancer journey?
I think the advice I'd give her would be to be on high-risk screening protocol. That's number one. You know, for these women that are considered high risk, we typically will calculate a risk calculation, which is their Tyrer-Cusack or their Gale risk, and we'll identify these women and identify different treatment modalities, which include chemoprevention in reducing their risk, as well as identifying, potentially given their history, you know, we individualize that care to say, okay, this patient would be a high-risk patient and could benefit from risk reduction mastectomy. It's given the family history, but that's, again, something to talk to your doctor about, something to talk to your GYN about, and reach out to your local breast surgeon.
Dr. Kesmodel, are there any other tests women should consider if they have a family history of breast cancer?
So as Dr. Coste mentioned, we consider putting these women in a high-risk screening program. And typically when women are in a high-risk screening program, they'll see a physician or another breast provider at least twice a year, and then they will also get supplemental screening. Typically, we will recommend a mammogram and potentially a breast MRI or a contrast mammogram alternating every 6 months. And the goal here is for early detection. And then, as Dr. Coste mentioned, for some women who are at high risk or have high-risk breast lesions, we do sometimes consider starting them on anti-estrogen therapy. This has been shown to reduce risk of breast cancer by at least 50%, so it's very effective. But again, it's about individualizing the screening for each patient based on family history or other risk factors.
Dr. Lewis, what other proactive things can women and men do to avert the risk of breast cancer?
I think looking at your overall health is important. So assessing how you're eating, assessing how you're reducing other comorbid or other illnesses and risk factors, because usually that's in alignment with some cancer risk factors. The next aspect is physical health, physical well-being, looking at your family history, being proactive, have a conversation with different family members who are alive. Do we know any family history of any illnesses? Because all of the information you can gather is important. And next, actually following up with primary providers, because some of your primary providers are your first line of this discussion. So that's important.
We have had such a great program and so much information. Dr. Kesmodel, 15 seconds of your final thoughts for our audience.
I mean, we know that breast cancer is currently not preventable. So I think it's really important for each woman to be proactive, to know your risk, stay up on your screenings, and also make good lifestyle choices, because we know that healthy diet, exercise, reducing alcohol intake, all of these things can reduce risk of breast cancer. Also, bottom line is we're diagnosing women earlier, and early diagnosis allows us to reduce treatments and lead to long-term survival and better outcomes.
Dr. Coste, your final thought, 10 seconds.
10 seconds. If you're a young woman and you are interested in identifying your risks, talk to your GYN provider. They're often the first line that can screen you and identify you and get you into the right physician that'll help you with identifying your breast cancer risk.
And Dr. Lewis, 10 seconds.
Not a problem. Number one, have family discussions about your history. Number two, go from confusion to clarity. Talk to your provider, ask questions, and discuss next steps together, because you are part of your care.
I want to thank our panel for joining us tonight, and our viewers at home too. For all you women and men out there who are battling breast cancer, don't give up. I'm here. I'm here. There's hope, and new therapies and treatments exist to help you. Thank you for watching our Beyond the Diagnosis Living Longer with Breast Cancer Town Hall. I'm Carla Hill, and a survivor, and I'll see you next time.
Thank you to the Eunice Joyce Gardner Charitable Foundation for its leadership support of the Health Channel.